Good morning, everybody. Jess is ready. So basically, the thinking behind this lecture is there's so much literature that's always coming out. It's kind of tough to keep up to date with things. I'm a big Twitter ID person, and I literally like every single article that comes up, and I try to go through them as much as possible, but it's tough. So the thinking behind this was maybe go through a couple of publications, not just studies that have come out in the past year that I thought were pretty interesting, that I hope everybody else would find kind of interesting too. Luckily, all the ones I chose actually ended up being published in the past couple of months, so all in 2023. So hopefully you guys enjoy. So the first one I'm starting off with is this NEJM study. It was post-exposure doxycycline to prevent bacterial STIs, published on the 6th of April of this year. This was a open label randomized study. So the purpose was to assess the effectiveness, safety, acceptability, and effect on antimicrobial resistance for Doxyprop in the MSM and transgender women population. And there's two cohorts. Patients on HIV PrEP, and then those persons living with HIV. So the method for this, so this was an open label study, powered to assess Doxyprop in those two groups that I mentioned. The participants were randomly assigned 2-to-1 to receive Doxyprop or standard of care without Doxyprop. It took place in two sexual health clinics in San Fran and Seattle. The participant criteria that I have listed there: 18 years of age, assigned male sex at birth, diagnosed with HIV or planning to start HIV PrEP, condomless and anal or oral sex with a man in the previous 12 months, and then diagnosed with gonorrhea, chlamydia, or early syphilis in the previous 12 months. Patients that were not eligible were those who had a tetracycline allergy or, of course, taking meds that could interact with doxycycline. So the intervention or the counseling that was done, the patient population, the cohort that received Doxyprop, they were told to take 200 milligrams of doxy within 24 hours, but no later than 72 hours after any condomless anogenital, vaginal, or oral sex, and no more than one dose every 24 hours. And these participants had quarterly visits at the two clinics I had mentioned. And they had interim visits in between as well for about a year. And the amount of doxy was kind of determined by how much the patients used themselves, how much they requested, and the frequency of their sexual acts. So basically given as needed to the patients. There was no restriction. They also performed quarterly nucleic acid amplification testing, the pharynx, rectum, and urine for gonorrhea, chlamydia, the triple screen that we do in our clinics as well. There's also quarterly syphilis serologies that were done. And those patients that had positive gonorrhea testing were actually asked to return for resistance testing as well. And the tetracycline resistance was defined as an MIC of 2. All the groups were also assessed for Staph aureus and the nares and oropharynx, and resistance testing was done for them as well, with the MIC of 16 defined as resistant. So endpoints that they looked at, the primary effectiveness endpoint was the incidence of at least one bacterial STI, gonorrhea, chlamydia, or syphilis each quarter. And then they also looked at antimicrobial resistance outcomes, tetracycline resistance in gonorrhea and Staph aureus. And then secondary incidence of each individual STI, safety and adverse events were looked at as well. There was they use a O'Brien-Fleming stopping boundaries to assess effectiveness, with alpha level on both sides being 0.025, and the actual board recommended early discontinuation and to recommend Doxyprop for all the patients involved in the study. So I know it's tough, but no. Yeah, there's a lot of pictures in here. So anyways, 641 patients underwent initial randomization, and At the end, 317 were in the PrEP cohort and 156 in the persons living with HIV cohort. Just some overall stats about the patients that were included. The participants in the 3 months prior to enrollment had a median of 9 sexual partners, 5 sexual acts per month, and 90% of these acts were condomless. And then 30% of these patients had an active STI when they were enrolled in the study. So I know this is there's a lot going on here too. Just some of the things I took away from the baseline characteristics of the patients. The race was predominantly white. Hispanics, Asians, and Blacks were underrepresented in the study. Another thing that I noted, there was a trend towards a higher annual income in the PrEP cohort compared to the persons living with HIV. I think some things can be taken away from that. Maybe they have a little bit higher health literacy, asking for PrEP. So that I think that could be a possible connection that could be made there. Yeah, exactly. Yeah, yeah, exactly. And I think that probably plays a big role here. And then there's a part of this. This is a long chart. The additional part of it showed. Oh, sorry. So the median number of sexual partners in the past 3 months were about the same between both cohorts. The persons living with HIV group actually had a higher prevalence of transactional sex during their lifetime. And then substance use in the past 3 months was also more prevalent in the HIV cohort. So this is the PrEP cohort results. So in the Doxyprop group, and this is overall, like I said, the PrEP cohort, STI was diagnosed in 10% of quarterly visits in the Doxy group compared to 31% in the standard of care group. Gonorrhea was the most frequent sexually transmitted infection that was diagnosed here, and the number needed to treat to prevent an STI in this cohort was 4.7. Most of the trends, although like the chlamydia, pharyngeal chlamydia doesn't reach significance, but kind of all trended towards lesser prevalence in the doxycycline group. And this is the persons living with HIV cohort. So here there was a 11.8% prevalence of STI to be diagnosed during a quarterly visit compared to 30% in the standard of care. Similarly, the gonorrhea was the most commonly diagnosed infection. There was a little bump in rectal chlamydia as well was seen here. And the number needed to treat in this cohort was 5.3. So just going over some of the other additional topics of discussion with regards to this study. So adverse events, there were not much. There were five total adverse events, 3 diarrhea episodes, 2 headaches/migraines. It was tough to kind of even attribute that to the doxy itself. Tetracycline resistance in the gonorrhea isolates was 38% in the doxy group versus 12 in standard of care. And the Staph aureus there was a 5% tetracycline resistance in the doxy group versus 4% in standard of care. The one thing that they mentioned, their cultures were limited. A lot of them, they weren't able to get cultures. They treated patients initially. Some of them didn't come back to get their resistance testing done, so there's not much endpoints. And then the other thing, Staph aureus carriage in the doxy group was 40% less than the standard of care group. So I guess that was a side effect of that. Additional points. So like I mentioned, there's a higher proportion, though limited, of Staph aureus resistance in the doxy group. Chlamydial cultures are still pending, so they're still collecting that data with regards to resistance and if there's a trend towards resistance or not. And then some other things to keep in mind is whether this will select out resistant Neisseria species, the effects on gut microbiome, and other effects on other STI pathogens. Limitations, it was tough to measure the adherence to doxypep and even sexual activity because it was all based on recall from the patients. So there's that limitation there as well. And transgender women enrollment was less than 5%, so that was not as many in that group. There was a trend towards syphilis reduction in the persons living with HIV, and there was a reduction seen in the PrEP cohorts as well. And this had picked up steam in the social media. I mean, in like media in general. I screenshotted this, so I'm sorry for the Xfinity on the side, but I'm calling it the morning after pill to prevent sexually transmitted infections.
Thank you for presenting this big talk in STD world the past year or so. And Arun, I know had to go see patients, but she was involved in the CDC call where they're discussing Doxyprop and deciding whether to put out guidelines about it and what to say about it and who to recommend it for based on these studies. This one and there's another one as well. The big question, of course, in the long term is resistance. You know, our treatment options are still limited already for some, for especially like gonorrhea. A lot of people argue that, well, it's not really antibiotics to prevent it versus none. It's antibiotics to prevent versus other antibiotics to treat.
Yeah.
You know, if you're preventing gonorrhea, that people would have gotten Septraxone for, like, how do you weigh these sort of? And I think Tyler's gonna tell us about that. And then the final concern about it is really, are we going to really get this to the people who need it? You know, and we see the PrEP, like, and you even mentioned it, the PrEP cohort tend to be wealthier. And this is even in, I think this was in San Francisco, where PrEP access is much more available than many other parts of the country. And so you do worry, are we really going to be able to get this to the people who are actually having multiple STDs and passing on multiple STDs, or are we going to be getting the more wealthier, often whiter people and population? So not that they should get it, but so should others. So.
Yeah. I think you did hit on a couple like interesting. So certainly like the PrEP arm, the follow-up was actually pretty good. Like even up to a year, over 90% of them are still following up. But a lot of that's going to be, you know, people who are more likely to get medical care, follow-up appointments, that kind of thing. Because that's what PrEP requires anyway. And then the group of the patients living with HIV, the people randomized to the drug arm followed up a little bit better. I guess the figure one, but it was like in the mid 80s, even up to like 85% still. But in the people who were in the standard of care, it was down to like 73% of the year. And even at like the first time point in 3 months, it was in the 77%. And that's a bias that happens in any study where it's an open label study. One person is getting a drug and the other person is not getting anything. So knowing you are enrolled in the study and receiving the intervention, patients are more likely to actually follow up. So that's, I mean, it's definitely a thing to kind of consider with this. And I think certainly if you have a compliant patient who's adherent to the care, shows up to follow-up appointments, very motivated, this is definitely potentially an option. I think if you don't have that, then you kind of really have to figure out how to factor into your practice, because you may only get, you know, 1 or 2 shots at seeing those patients. And so you want to make sure you're optimizing everything with those opportunities. And then the other thing too, this is just kind of like an aside. I know up every once in a while when we talk about it, but the PCR test for gonorrhea, when you test on the pharynx, will cross-react with Neisseria and posterior oropharynx. So it's harder to diagnose oropharyngeal gonorrhea with that test. You have to almost do a culture, but that's obviously time intensive and not practical. But it is something to just consider when people are using that to diagnose oropharyngeal gonorrhea, that it might not be the best test. Dr. Morsani has.
Yeah, hi. Thank you so much. Can you all hear me okay? This is so exciting and so timely. Y'all can hear me, right? So we actually gave a national VA orientation to Doxyprop yesterday, which was really great. We're happy to send those slides out. I send them to the VA faculty, but certainly can send them to the broader audience. 2 great presentation, 2 major points. This is a great study. Of course, it all started with the Ipergay study, which was the PrEP study in France. And fun fact, it actually started with U.S. military prophy. They started STI prophy back in the 1940s with penicillin and then tried azithromycin. And so tetracycline was kind of the newest. As you remember, the ciprofloxacin resistance with gonorrhea back that occurred. So yes, we'll definitely see. But yes, the early data is definitely reassuring. Second important point, I think this was not effective in cisgendered women. The CROI data from 2023 showed, unfortunately, was not effective in a Kenyan cohort. So that's important too. Right now, it's just for anatomical males, so transgendered women and cisgendered males. So that's, I think, important point also. And also prescribing. So in VA, we are rolling this out. We're really excited about it. But for policy implications, the prescribing obviously should match the indications. We had one interesting case where the patient was self-treating for URI. So you have to be obviously very good about your education. I think your institutional policies in terms of, making sure that prescription actually reads the way it's supposed to be taken. But no, very, very exciting, and happy to share. We actually did a CROI abstract analysis on all these data too, so can share that with the faculty and fellows widely. But thanks, great, very timely and very exciting.
Thank you.
She took the words out of my mouth, but exactly what I was going to comment on is cisgender females, exactly. Effective. Another implication in women of childbearing potential, right, is if they're pregnant, or genetic. Another thing is the prescribing has to be we have to be great stewards if we're going to do this, and we have to just, do the appropriate dosing and the day supply, because we did have a case at the VA, a person living with HIV, who had like a 30-day supply of Doxy, not any of our providers, and was told by their provider, just use it after, you have an exposure. But then he got TB, LTBI, we put him on INH, he got a rash on INH, and then he quit it, obviously. And then he tells me, oh, and I also took Doxy around the same time, the rash, or why were you taking? And it turns out this was the reason why, but he had like this permitted. So, and where do you actually had an exposure? No, I just had a story. So patients who you cannot give these antibiotics to patients and let them do whatever they want to do with it. So I thought maybe this could be a hypersensitivity reaction that you could get with Doxy as well. So it just was really a limitation of blood reaction. So if we really do start rolling it out and we start doing it, be conscientious of the prescribing.
Yeah, I was thinking like patients might start to share it with us. Partners. We hope they have allergies, and now anyone is getting one.
Yeah.
And the potential for resistance, obviously.
Yeah.
And just the side effects as well, like pill-induced esophagitis, don't forget about that, the GI disturbances. Let's go on.
Yeah. It feels like these kind of patients also, if they don't have HIV, they should be on PrEP.
Yeah.
If they're using Doxy for morning after, they should be on PrEP. Be on PrEP.
Yeah.
At least at that time, you'll have that 3 months follow-up and testing for gonorrhea. Yeah. You don't want to undertreat also an STI because they might acquire it and then they're taking the one-time dose.
Yeah.
Just the way that this article states it says morning after, and it sounds like it's like a one-time dose or something. I don't know. It just sounds.
It's represented very bad.
Yeah, it's just a one-time.
Has anybody looked into what the implications are for doing stuff like this and seeing if that socially kind of emboldens people to have condomless sex, therefore increasing the rates of things that aren't controlled with doxycycline, viral infections, herpes, HSV, that sort of thing. So is that an inadvertent side effect of saying, oh, you have doxy, you're protected from gonorrhea, chlamydia, go wild?
So I think people are going to have condomless sex for
Sure.
Right? In the back in the days, we used to tell people abstain. We know that's not.
No, of course
right?
not.
So the same logic was used for PrEP initially, right? Like, are we going to give them PrEP? Or are they going to just? Right. But I think people's behavior, they're not going to change. They're going to engage in risky behavior regardless, I think. And I think PrEP and this is just, well, you engage in that behavior, let's remedy it, let's treat it, because a strong indicator of future behavior is past behavior. So people are not always change their behaviors. But I totally.
But that's an important part of the counseling, just like it is for PrEP.
Yeah.
Right.
PrEP doesn't prevent STIs. Doxycycline does not prevent HSV.
Yeah, this is Yeah, no, that's good. Can I just add? I'm sorry. This is really great. And I think and also what the VA does and what we do in our telehealth practice, we give a orientation sheet. So we actually have a PrEP orientation sheet, HIV, Hep C, SSP for syringe. And so I think in terms of policy, absolutely, I think a nice counseling sheet that, providers are consistent is important. And yes, people are going to have encounters, really, regardless of medicines. And that's what we're trying to do is actually decrease that harm potential with prescribing. And exactly, PrEP and Doxy, it's really intertwined, I think, at this point, because the evidence is there for cisgendered men and transgendered women. So yeah, no, I think that's great, but I think it only benefits the situation.
Yeah, I guess my question is more so for people who maybe like, does the incidence of high risk behavior go up more so than do people like people who are gonna kind of have these encounters are gonna have these encounters. You're 100% right. So you might as well kind of mitigate as many risks as possible. But I'm just curious if, like, especially with articles like the one he's showing, is there maybe a, it's like a little too much of a sense of safety if we promote it like this, and therefore like incidents go up for people who maybe normally would be a little bit more cautious. Does their condom use go down, for instance? Does it go from, being 10% of the time to 2% of the time, for instance?
Right. Like, does this increase condom sex, basically?
Right.
Like with PrEP, like,
right.
If you see increased STI, there's some data that suggests that there's increasing STIs in people on PrEP.
Right. I understand that there's not like a straightforward, like, this is the right thing to do, and that, risky behaviors are going to continue. But, especially between that and the, people kind of just willy-nilly using it for God only knows what, and maybe using it in, ways where, they can make themselves really sick with other polypharmacy. They've got the supply of doxy home that they just, are taking with, and they have a acute medical condition for which they get a new med, and now I got sore throat, and so I don't know. I don't know if that's part of the counseling on the VA side, as far as like appropriate.
I can speak to that. Well, first of all, I mean, this article, if you remember, is vox.com, right, which is not really a public health, right? So public health messaging, right, is a little bit.
Nobody's reading the public health things; they're reading Vox. So.
Right. No, I'm with you. But I think messaging is important, absolutely, right? And yes, the VA does counsel, and we're still in the process. Each facility has a different protocol, but yes, we do counsel in terms of harm reduction and risk reduction. Yes, and yes, did we see incident STI increases a bit with PrEP? Yes, but we have to do harm reduction, and it evens out over time. So I think the evidence shows that the trajectory, right, the arch of harm reduction is bending in the favor of HIV prevention. Many HIV infections averted with PrEP, right? So yes, I agree, and the messaging is important, but on the whole, I think we'll see that we're having averted STIs, and the evidence is clearly going in that direction. But those are excellent points.
Gotcha.
Awesome discussion. So next one I have hydrocortisone and severe cap. So me and Dr. Green, when this came out, we're going over it and geeking out. So this was published. We were at the VA working together. So this was published March 23rd, 2023. So this was a double-blind, randomized controlled superiority trial conducted at 31 French centers. Adult inclusion criteria: 18 years of age, admitted to ICU for severe cap. I'm going to get to how they define severe cap. Non-inclusion criteria: DNI status, pneumonia secondary to influenza, and patients with septic shock initially. Upon admission to the ICU, they were not included. Diagnosis of pneumonia was through clinical and radiologic criteria. Pathogen identification was left up to the medical team in the studies that were. So how they define severity of pneumonia. So presence of at least one of the four following criteria: mechanical ventilation with a PEEP of at least 5, high flow nasal cannula with PDAF ratio less than 300, non-rebreather, less than PDAF ratio of less than 300, and then a PSI score greater than 130. We probably learned about PSI score during residency. So I just have criteria that they use are age, comorbidities, and then look at specific lab values such as sodium, glucose, hemoglobin, things of that sort. So the intervention that was done, so standard of care, antibiotics, and supportive care was done by the medical teams themselves. Choice of respiratory support was by the medical teams themselves as well. What the intervention that was done, so within 24 hours after onset of severity criteria, which we just discussed, IV hydrocortisone, 200 milligrams daily, was given for at least 4 days. Now, the total duration was between 8 to 14 days, depending on the patient's clinical condition. That was kind of determined by there were some predefined criteria that was given to the teams, and they decided based off of that whether to extend therapy to 14 days or complete therapy at 8 days. And of course, on discharge from the ICU, they were discontinued from the hydrocortisone, and the patients were randomized 1-to-1. So outcomes that were looked at, the primary outcome was death from any cause at day 28. And there's a good amount of secondary outcomes as well that are pretty extensive. Death from any cause at day 90, length of ICU stay, need for non-invasive ventilation or intubation among patients that initially came in with non-invasive ventilation, initiation of vasopressor therapy by day 28, ventilator and vasopressor free days, change in P to F ratio, change in day 7 of SOPA score, and then quality of life by day 90. The interesting thing, this was actually started before the COVID pandemic, and they had to kind of put a hold on it once COVID hit in France, and just because of the burden of everything that was going on in the hospitals. P-value of 0.049 was considered statistically significant, and they used a chi-square test to analyze day 28 mortality. So, another picture. So anyways, 400 patients were in the hydrocortisone group versus 395 in placebo. So 795 total included in the primary analysis. And the baseline characteristics there weren't much significant differences from when I was going through the baseline characteristics. And sorry, I didn't mention this. The reason why I decided to include this, we have 2 fellows going to ICU next year, and we often are consulted on ICU patients. So this is something that would be beneficial for us to know.
Thanks.
Anytime. So yeah.
They did do a statistical analysis, but there was more people with COPD in the placebo arm.
Right.
Important for pneumonia.
Yeah.
And steroids. Withholding steroids too.
Yeah. Thank you. So here are the primary and secondary outcomes. So in the hydrocortisone group versus the placebo group, the hydrocortisone group, death by day 28. The total number was 25 patients out of 400, so 6.2%, versus placebo was 47 patients out of 395, 11.9. There are trends towards lower death by day 90, cumulative incidence of endotracheal intubation by day 28, and non-invasive ventilation by day 28 in the hydrocortisone group as well. The safety outcomes, so yes, the percentage of ventilator-associated pneumonia and bloodstream infections were a little lower in the hydrocortisone group, which I found surprising. I would have thought that they would have been a little more immunosuppressed and possibly would have had more complications related to infections. And then even the GI bleeding, cumulative incidence of GI bleeding was a little less in the hydrocortisone group compared to placebo. Which I found interesting as well. The one thing that jumped out was the amount of insulin the patients required in the hydrocortisone group was pretty high. I think the average daily dose of insulin was 33.5 in the hydrocortisone group versus 20.5 in the placebo group, which also plays a big role in ICU management and care with the always quoted nice sugar trial back in the day. That the ICU attendees would talk to us about. But I found that pretty interesting as well. So I think the exclusion of septic shock was important, at least in initial enrollment, because we know the benefits of septic shock, of steroids and septic shock from previous studies. And in the study itself, they mentioned that the pathophys processes and role for glucocorticoids and septic shock differ, which is why they decided to make that decision. Some limitations. So no pathogen was identified in 45% of patients. And the one thing they had mentioned was the observed mortality in the control group was lower than what they had anticipated, which I thought was interesting. So could possibly mean that the control group that they had was not really representative of the population they thought they were getting. So I think that's an important caveat. There's a small percentage of immunocompromised patients in this study. No one looked at afterwards the reversibility of glucocorticoid-induced hyperglycemia and whether some of these patients had or developed diabetes later on. That was not taken a look at. The neuropsych and neuromuscular effects of glucocorticoids was not commented on. There's no standardized use of antimicrobials. And then they also use continuous dosing of hydrocortisone and not the bolus dosing that we sometimes use for septic shock often. So I don't know. This is my last slide on this study. I don't know if anybody has any comments on that, or we can save it until the end.
I think you commit at this point excluding the hydrocortisone because that's a clinical study. There's no mortality benefiting because it was like time to stability patients with septic shock. So it is really important to kind of try to remove that as part of the equation because we do know there's at least something suggesting there's a benefit of just steroids alone and like.
Yeah, go ahead.
I think it's kind of a benefit because in septic patients there's a early recognition of sepsis, and maybe when we get these patients with severe pneumonia on the ICU, that there is a benefit of early steroids. I think one of the things that really stood out to me was to see less vasopressors and less non-invasive basement patients that receive steroids. Maybe that you're catching it like in the earlier day.
Yeah, I think that's definitely. I mean, it makes sense. So my third article is from the Journal of American College of Cardiology, published on the 4th of April. Found this one while I was on the VA service with Dr. Ayler. I think we had a cardiac device infection patient in the ICU, so I thought this was pretty relevant. So this wasn't a study. This was just a review to assess the burden of these cardiac device infections on healthcare, evidence for treatment, and the barriers to treatment and early diagnosis. So address gaps in knowledge and why there's a poor compliance to recommendations, which from our end is always to kind of take out the device as soon as possible. And they looked at a lot of literature review of papers published in the past 15 years on this subject. So just going over the economic burden of cardiac device infection. So the RAPID trial, cardiologists always come with great names for their trials. So the mean payer cost per infection with Medicare Advantage was about $58,000 plus or minus $29,000. And with Medicare fee for service, it was around $26,000 plus or minus $14,000, which is pretty significant cost. They had some cool images in this study. I would definitely recommend people taking a look at the study. With the localized pocket infection, device erosion in C, an actual angiovac vegetation that was taken out in C, and then a lead vegetation in D. So clinical outcomes and healthcare utilization, a couple of things that they mentioned. So there's a retrospective study of these cardiac device infections from 91 to 2008 that found that antimicrobial therapy alone without device extraction was associated with a 7-fold higher 30-day mortality. And even early versus delayed extraction also revealed differences. Extraction on initial presentation compared to those who had extraction after antimicrobial therapy had a 1-year mortality of 11.4% versus 44%. So pretty significant. And there's a recent analysis of the Medicare population with only 25% of these patients undergoing extraction, and cumulative 1-year mortality at 30 days of this particular population was 33% versus 18.5%. The one caveat, these studies aren't randomized, and the delayed extraction cohorts probably had older patients, more frail patients, and patients with more end-stage diseases, which is a thing to take into consideration. Okay. So there's generally 5 guidelines that give recs on these device infections: AHA, British Heart Rhythm Society, European Society of Cardiology, and Heart Rhythm Society. And they all have class 1 indication for complete system removal with a defined infection. Systemic.
And the IDSA does sign on to the AHA.
Okay.
It's AHA, ACC. It's like American College of Cardiology, American Heart Association, IDSA. It's a ton of
They all jumped on.
2017. Yeah.
Okay. So they basically infection with a systemic local bacteremia or endocarditis, and it's all a class 1 indication for complete system removal. But recently, looking at a recent analysis of U.S. Medicare database, greater than 8 out of 10 patients were not treated according to guidelines with early, which is pretty high number, especially for us. I mean, I think we're always about taking out the device if possible, and just with the burden on the system overall, I think it's important to take into consideration. So here there's 2. This is a graph on 1-year mortality for cardiac device infections, with the top is extraction versus no extraction, and the bottom chart is early extraction versus delayed. So the article does a good job of kind of identifying different barriers to guideline adherence. So first is identification of the actual infection itself, prompt referral of these patients with infections, and access to extraction. So there's a study from European Society of Cardiology where they sent out a survey to try to identify these barriers. So besides the gaps in knowledge, physician knowledge, and skills in diagnosing these infections, there's referral barrier, there's access to extraction center, and the interesting one that they had found from the survey was there's a fear of losing a patient to an extracting physician, which I thought was pretty interesting. And then, like the physicians that they sent the patient to get the device, they just stay with that doc and not go back. Yeah, yeah, it was just pretty interesting. So I guess cardiologists are humans too.
I wouldn't go back to that.
And then they, of course, mentioned patient comorbidities, age of the lead, as being additional barriers as well. So this is a pretty cool illustration that they had in the paper, kind of talking about some of the risk factors for device infections, the different manifestations of pocket infection versus systemic infection, and the key stakeholders in these patients, and the barriers and how to kind of address these barriers. They, of course, they gave us a shout out and said timely involvement of infectious disease to help in management is important. Another option they mentioned to kind of address this issue was incorporating an EMR alert system where physicians are sent an alert about positive cultures in patients with device infections. And I think that's been implemented in some places with some trends towards improved management of these patients. Yeah, that was, I think.
I was gonna say, I feel like most of it is just like,
Yeah.
we're like, remove it.
No, they
It takes 15 days to remove it.
Yeah, they talk about like the comorbidities, the age of the lead, like how invasive
Yeah.
yeah, they mentioned that too. Because I think that's something that we fall or encounter a lot with extraction and the hesitancy.
In general.
Yeah.
Getting rid of any hardware at all, ever. Yeah.
Like a band.
Just sometimes we don't think about how easy it is to put in a new device.
Yeah.
How can the patient survive without that hardware sometimes? And can they have any mobility in their knee?
Mhm.
We kind of look at it To remove it.
Exactly. Yeah.
Same with the catheters, right? For people that they use for people.
Yeah.
When to remove it.
A large proportion, if not a majority of people with pacemakers are not actually paced. They are, and you can, I mean, you'll see them in the hospital. They're like, you can see like the patient pipes are barely firing, they'll interrogate it, and it's not really done because they had someone classified that was like sick sinus syndrome and that had AFib at one point and the device was understood. So especially in those patients who aren't even requiring pacing, even more of a reason to take it out or not to get hesitant about it. For y'all too, I would really encourage you to go read the 2017 guideline. It's one of the best written consensus guidelines out there in terms of management. Very clear management algorithms. It goes through all the literature. It does the IDSA one in 2017. They kind of made this new, I guess, AHA, IDSA, ACC, all this. They made this new exception for people who develop a device infection within the first 30 days, where you're allowed to basically try to target skin flora to see if you can not have to take the device out and reassess them, fail, the device doesn't come out. But that's actually based on just expert opinion, with very little additional data. It's kind of like this carve out exception right after the device is put in to say, is it just localized to kind of the incision point to get away with not having to treat it, assuming of bacteria. And then everything else is kind of broken down by organisms, so like staphylococcus dioxide, device pumped out, bacteria in the blood, for the valve versus some other ones. It's kind of, you kind of mixed areas where you need your TE side and you're gonna have to do extraction or not. So I would encourage you all to go look at it. It's very easy to read, straightforward, clear, and then kind of go into it. You can go into all that study with it based on what they talk about, because you already showed it. I mean, there's other things too, like the morbidity and mortality is through the roof, especially the device.
Did the article comment at all on newer leadless pacemakers and whether they're anticipated to reduce infection or have different complications?
Yeah, they didn't mention the leadless pacemakers, but I mean, I think that'll help us in terms of our management if the patient needs a pacemaker, and then lead to lesser invasive infections. I think that's important with the leadless, but they didn't mention it in the review.
To make it harder to extract them.
What big thing with the lead, like he said, the first 30 days, the reason says bleed then doesn't get wrapped in the myocardium. And one thing we always have to think about is there are a lot of hospitals that can't deal with extracting out those leads embedded in the myocardium. You have to send them to an expert center, and that's where all it is. And to another point, what he said is a lot of people they don't have the pacing going on because fortunately 35 years ago, a lot of patients were implanted probably that they need to be implanted because they were misdiagnosed. So our aging population is now getting more and more of these. Hopefully with like leadless and all that.
So piggybacking on what Arun said, right? What organisms would you be more, driven to remove a line or a device? That's important to know for your boards. So staff, does it matter if it's MRSA or MSSA?
Yeah.
Okay. Probably pseudomonas.
Caucus.
If it's high.
I know, yeah, multi-drug resistant organism.
That's important to keep in your right, because I know this time gets muddy, but those organisms, it's like.
So actually for the IED infections, even coag negative staph is an automatic indication to pull it out because that's one of the most common, if not the most common, causes the IED infection. So you're going to see them all the time, but like we have there's someone I had last month at TGH who has a pacemaker and like persistent staph bacteremia. They couldn't necessarily find anything on the leads, but like auto that comes out because it's such a high risk of being on there and seeing the device. That's interesting.
Even some even some bacteria that are listed on there, but like there's troublesome. Like I've had a patient with corynebacterium. Exactly. People see corynebacterium. They called us after a week after it came on, but they thought it was skin or whatever. The guy had a pacemaker for about 2 years, and then it kind of showed corynebacterium in 4 out of 4 bottles through You know, I was like, that needs to come out. It shouldn't go up anywhere in Cordyceps. So it's not listed as one of the bacteria, but as ID physicians, we know that can be a troublesome kind of thing.
Just for the fellows, what's your other gram-positive law that's integral that you would be concerned with CID? Normally you treat as skin contaminant, just like staph and bacteria. Oh.
Yeah, you said it.
No, you- Thank you. Older name was.
Cyanobacteria.
Bacteria. So those difficult to treat organisms like heating organisms, bacteria, sometimes micrococcus, as well, maybe NPMs, also very.
NTM too.
So if you have them for you, then you get it.
Pacemaker, yes.
Yeah. You should, but again, look at everything.
Right.
There's a risk factor up there.
And really, to that point, when you look at the algorithm, the only way to really prove that you truly don't have a CID infection is with a T. That's something that we always push for too with these patients. Like you have to get a T.
But even if negative,
But but
just take it out, right?
ideally, yeah, ideally.
Yeah, so like,
Last one in the picture.
in that guideline, it's great. I mean, it literally goes through like by organism, like co-negative staph, staph aureus, P. acnes, whatever, the ones that are just very high risk. Doesn't matter what your TE says, doesn't matter. You still get it. Determine when you put a pacemaker back in, your duration of antibiotics, that kind of thing. Do they have concomitant endocarditis? Treat for that too. So you're going to get the TE, but regardless of the result, some bug, negative staph, staph aureus, P. acnes, it's out. It doesn't matter. And then the other ones, it's kind of like negotiable based on the clinical status of the patient. But I mean, that's what's great in that guidelines. It just goes through every single one, and it's very easy. So, yes. And most of the people that you were talking to, their academic society signed on to that guideline too. So, yeah.
Okay.
Awesome. So next one I have, shout out to Dr. Canella. This was an abstract presented at ID Week 2022. This is the only one that I have from 2022, so that's my fault. So clinical outcomes of ORDAPinum in patients with hypoalbuminemia. So methods and outcomes. So this was a retrospective observational single-centered cohort study of patients, hospitalized patients at Loyola Medical Center. Primary outcome was 30-day all-cause mortality. 146 patients ended up being included with a 73 in each cohort group with a the definition of hypoalbuminemia that was used here was a serum albumin less than 2.5, being the hypoalbuminemia group. So baseline characteristics, age, sex, nutrition status, comorbidities were pretty much the same. There was more CKD seen in the normal albumin group in this study, and there was also more ICU patients seen in the hypoalbuminemia group here. So both of those should be taken into consideration with some of the results that were here. They also collected Apache 2 scores and Charlson Comorbidity Index for these patients. So here we have on the left is a hypoalbuminemia group and greater than or equal to 2.5 albumin on the right, and the p-values you see on all the way on the right. So there was trends towards increased length of stay. Sorry, I forgot, I didn't mention. These patients all received once a day ORDAPinum. So that was the antibiotic that they received, and very highly albumin-bound antibiotic, and that was what was used here in both these cohorts. In the hypoalbuminemia group, there's increased length of stay, ICU length of stay, and infection-related length of stay. Granted, there were more ICU patients in the hypoalbuminemia group, so you would kind of expect a little bit of that trend regardless of the albumin group. There was higher hospital readmission in the hypoalbuminemia group, and trends towards mortality being higher at 14, 30, and 90 days in the hypoalbuminemia group, but there did not reach significance. So some of the things in terms of thoughts on this, the study suggests that subjects, with hypoalbuminemia receiving ertapenem had suboptimal clinical outcomes. I talked about the caveats earlier. But I think either way, therapeutic drug monitoring is something that is, needed at most of our institutions, but it's tough to have. And the other question is whether this can be extrapolated to other highly albumin-bound antibiotics like Septraxone. So yeah, no, they didn't. Yeah, they didn't break it down. I also could, the study that I found it wasn't very extensive, so I'm not sure if they fully published the whole thing. So I think that was the other thing. I couldn't get exact information. I did a lot of digging for it, but yeah, they didn't kind of break down the types of infections. Yeah. Dr. Yes.
Any small motion like this comes up when we talk about ertapenem versus meropenem. There's a really good, it's a retrospective study, so it's good you can give that. Study from Israel in 2015 by the first author's last name is Zusman. But they basically looked like if the institution patients who got meropenem versus ertapenem, and the mortality was higher with hypoalbuminemia, and the inflection point was about 0.5. So, personally, that's kind of my cutoff. Is if you're less than 2.5, I won't usually do ertapenem unless it's like urinary tract infection or something with drugs can concentrate. But particularly for like severe infections or you're not going to get spore control or something like that. And then for your question about Septraxone, really good one. There's a paper in OPID actually, I believe it was this year pretty recently, where they looked at same sort of thing, albumin and Septraxone. The main point from it is there was actually no difference in clinical care, even when it was used for bacteremia. I'm sorry, that's what it's for bacteremia of Enterobacteriales using Septraxone. There was no difference in outcomes. The exception was critically ill patients in the ICU. They trended towards a higher mortality. It was close, but did not achieve statistical significance. There's been a few times, like I think last month we had a guy with albumin 1 with pleb bacteremia or something. I didn't use Septraxone, but it at least, I don't think you need to be as dogmatic with Septraxone as you do ertapenem. I think the data is a little bit stronger for ertapenem compared to Maros versus Septraxone compared to like Septraxone, for example. But certainly you have to be kind of careful, especially when your patients get down to like 1 or extremely low levels of albumin.
So interesting. Would you double the dose at that time to try to overcome it, or you just change to another antibiotic?
I just use Septraxone.
Yeah. I think that for everything.
Yeah, if they're less than 2.5, and this is, of course, this is assuming you don't have like another option, right? You don't have like a it's gonna get high and treat the same organism. But if you're stuck using a beta-lactam and you're in a severely hypoalbuminic patient, then I'd probably use another one.
So what Guy is saying is correct. There was no mortality benefit, but there was a morbidity benefit. They also noted in that study and a couple other ones afterwards about Septraxone that for Enterobacteriaceae specifically, as people who have hypoalbuminemia use Septraxone in those cases, there is a tend towards resistant pathogens and resistant clones developing, which is a problem. And that means that later on, you're in deep doo-doo when you try to use it or other cephalosporins, as they would say in the UK. And so this also goes along with a lot of other drugs that are highly albumin bound. So there are certain papers that will suggest that you can actually increase the schedule of ertapenem and Septraxone to overcome the hypoalbuminemia. And that looks like it could work. We've done it in a couple of cases here at the VA, but for the most part, it's still a little bit more science that needs to be elucidated. However, the need for therapeutic drug monitoring is massive. And again, at UF, they have this, and you can get levels and actually see what's really going on and match it up, with your Monte Carlo, simulation, all this stuff to see exactly what's happening with your beta-lactam level and the MIC at hand. And hopefully you have, it's not a heterotropic, organism that's heterotropic to the antibiotic that you're using. But still, it is a point to be made. And I think that this is very important when we give people antibiotics And, especially for something like staph, where we use cefazolin or the second generation penicillins. And yeah, it's true, staph takes a long time to get rid of out of the bloodstream. But at the same time, could it be because their albumin's low? We also have to understand that albumin is also an inverse acute phase reactant, where it actually goes down because the liver is trying to make certain proteins and lead the protein production more towards complement and globulin, so that plasma cells et al. Can do what they need to do to quell the infection. And so that is also an issue. However, I would argue that it's important both in an outpatient and an inpatient setting. And so, for OPAT, I see these patients all the time that are on, daptomycin, or as I call it, craptomycin, when they go out, and they end up having a bad outcome, or they fail. They fail the drug because of that. So again, it's just something to be cognizant of. We usually are so worried about levels of, the aminoglycosides and vancomycin and et cetera. But beta-lactam therapeutic drug monitoring is a very, very, very important thing. And we should be doing more of it and investing more into it in our hospital settings for ASP.
The last thing I said, and I know you'll know this intuitively, but I can hear my micro director when I was at Fellows telling me this, but for Enterobacteriales, you can have ORDAPinum resistant, meropenem susceptible, and depending on where you're practicing, your VITEC may only give you one of those. And so before you use one or the other, you need to make sure it's still susceptible. It's usually a meropenem susceptible, ORDAPinum resistant, but just make sure that it is susceptible before you do that. Don't just kind of say, oh, it's meropenem susceptible, and then for case. I don't know if you have any more cases, but this was fantastic.
I have two more. Yeah.
Exceptional.
Two more, but nothing crazy. It's interesting stuff. All right. Thank you for hanging in there with me. All right. So.
Okay.
So this is a cool article, very quickly published in Antimicrobial Stewardship and Healthcare Epi March 1st. So post sign-off events and ID consultation and incidents of non-adherence to ID recommendations of the post sign-off a retrospective cohort study. I thought it was pretty interesting. So methods here. This is a retrospective study done for a year in 2019 in Tokyo 790-bed medical center. Overall, around at this specific institute, around 700 patients annually receive ID consultations. I think compared to us over here, it's low. They had 2 board certified ID attendings, 2 ID fellows, and then rotating residents on the service. And then multiple ID consultations. If they had multiple ID consultations in hospitalization, the first one was used in this study. And then if they had multiple readmissions, just the first admission ID consultation was used as well. So other than EMR documentation, the ID team communicated the actual recommendations to the primary team in person or over the phone. Participants were all patients who received ID consultation. Exclusion criteria: outpatients, curbside. Cases where the ID recommendation was discontinue antibiotics as the final rec. And then ID recommendation where there was no treatment duration given for antibiotics. So data collected and some of the definitions. So post sign-off events, they defined as treatment failure, antibiotic-related adverse events, hospital-acquired infections, withdrawal of care or ID reconsultation, adherence to ID recs following final recs, including antibiotic regimen, dosing, and duration, and then non-adherence to ID recommendations and the reasons why were also attempted to be collected, although the reasons for non-adherence were not often documented in the notes. So hospital-acquired infection, they defined as infection within index hospitalization appearing 48 hours or more after admission. And then they used a multivariate logistic regression to predict factors associated with non-adherence. So eventually at the 740 patients initially looked at and 367 included at the end in the study, the top 3 departments that provided consultation for ID was crit care, general surgery, and ortho. So there's post sign-off events in 16% of patients. I'll just quickly go through some of the high points because I know there's a lot of stuff going on here. ID was reconsulted in 61% of patients in the post sign-off period. Non-adherence to ID Rex was seen in 15.7% of patients. And 45% of the patients in the non-adherent group had premature discontinuation of antibiotics. One of the things that the paper mentions that some of them had been discharged by the time before antibiotics were completed, so that could have been a reason why some of the antibiotic courses were cut short. And they identified development of a healthcare-associated infection being the primary reason for non-adherence after ID sign-off. There's a lot more interesting stuff here, but I know we're kind of short on time. So they looked at the two groups, non-adherence and adherence on both sides. There was an increased length to discharge and a length of stay in the non-adherence group. And then there are also there's some interesting stuff in terms of length of from ID consultation to sign-off period and length of ID consultation as well that were shown here in the study. But I think some of the real interesting things is how they brought up we can address this. So, of course, they mentioned how ID sign-off, that post sign-off period has shown that patient safety declines. Some of the things that they mentioned is they said that the ID team should have, keep some of these patients still on their list and check up on them occasionally, which when you're getting 700 consultations a year, could possibly be okay. But for us, it's tough.
So the standby list,
yeah, similar, an extensive standby list. But I think the other thing that it identifies is that we need to have thorough sign-off notes, not only with our recs, but if this were to happen, do this. I think the people who consult us sometimes need very explicit instructions from our end, and so I think documentation is just what's really identified here as being the real focus from our end. So I don't know if anybody has any.
It's interesting.
Yeah.
Like coming from this is just a funny little tidbit from Houston. We were told not to specifically put in discharge instructions till the ID person, like the physician, felt comfortable and was like, okay, now they can go, because the moment you put it, could go on oral antibiotics with this one, they'll be like, all right, discharge, and then you'll be like, they're not on my list.
Yeah.
So things like maybe holding off saying oral till you were like, everything's done.
Yeah.
That was one thing that we did, because we knew that it'd be a bad outcome if they just went on oral. They probably need another week of IV, something, or a checkup from the surgeon, making sure that this tube to come out. So that was one little kind of thing I used a lot. Just say, I know you want to get your list down and you want to do it, but try your best to avoid doing that, because they will jump the gun and be like, hey, sweet, how are all antibiotics being go?
Yeah.
So that was like one little small thing that I changed, like my habit changed for that. So
we did a similar thing in my fellowship where you often want to put the full discharge plan in until you were sort of ready to commit to the final discharge plan. Mm-hmm. Very different culture from here, where everyone wants to plan like on the day of initial consult. Are we going to need a pick? Are we going to, what's the plan?
Yeah.
So I just want to add about this. So in our culture here at TGH, unless you're really willing to have totally hands off on the patient, you can't really sign. Because people rely on us to help the patient from infectious perspective. It might be different at Moffitt, but it's not that much different. The main difference is they have more bandwidth of ID pharmacists at Moffitt. So when the patient is off and got discharged, the culture still be closely followed by first shift team. So one of the things that we implemented about two academic years now, but have revamped drastically during the last academic year, was having a non-teaching backup team to upload the teaching team, and actually the main goal of the backup team or non-teaching will be for discharge planning. So you not necessarily need to don't sign off too early, because even the patient on our
follow-up list that was discussed in this paper. We not technically sign off, but we have to be clear, like how often you're gonna see this patient. And when you say that and commit to it, like when you see a patient twice a week, see a patient twice a week and tell them when you're gonna see a patient again. But when you have the sometimes the patient in your workup plan is not really completed, but almost there, and you need to get the load up to down to the end of your cap, and then you should sign out as well to the backup team so that they know what you're following and what is the whole up like that. We have budget for the team, so if you all know that we get a lot of help so that your cap is within what we had agreed on that is good for your learning.
I think it's always a balance of you want to keep enough patients and you want to follow and have that patient safety and be on top of all the patients, but at the same time, you don't want your list to go to 35 when you're acute patient who needs actual care, like intensive care by us, just having to be brushed off so you can follow 5 patients who have a plan. And that's where the non-teaching team is, like you can move patients there. But I mean, if they reach 30, then they're going to have to. But yeah, I think it's pretty interesting. And I do believe it that when we sign off patients, the care does dip a little bit. Even if we have a final antibiotic plan, because things happen. Sometimes resistance happens, infections, you can have a recurrence, whatever. And they don't notice it as fast as we would have done it if we were seeing them. So.
The other thing I would say, if you're going to have to deal with this in your practice is if you have recommendations that's medically right for the patient, you shouldn't compromise that because of something like this. Obviously, you need to be trying to do whatever's evidence-based for the patient. We're constantly learning things we're doing now are wrong, and we're going to learn how they're wrong and we should be doing them in a different way. But if you have a specific way that the patient medically should be treated, you don't need to be making compromises just to get them out of the hospital or things like that necessarily to expedite their care. That being said, I mean, a lot of things like, we talk about is like IV to oral antibiotics for bacteremias or osteo. I mean, we're getting more and more data for that, and that's might be the way that we're going to go starting to treat those patients. But probably had experiences where you're called and say, hey, can we do this or that to make it easier to treat? And that might not be the best thing to kind of treat what's going on there. So.
In the sign-up notes, this is something that the brain always tells us is, you really should be as specific and explicit as possible. And that means drug of choice, primary regimen, dosing, frequency as well as duration and end date, lab monitoring for, and the frequency for that and which labs you want to get. If the patient needs to go on a big one, if it's going to be IV or PO, and if they need any ID clinic follow-up as well. So if you guys stick to that explicitness in your sign-off notes, that will also kind of maybe decrease the questions or doubts from our consultants, people that are referring patients to us. And also just kind of also leave it open. If you have any questions or concerns or just call us. And if you switch an antibiotic, you say, okay, no, that's not the plan. Let's switch it to this alternative. Stop. And it'll keep you guys.
All right.
I think this is a good, strong argument for a standby list, huh?
Mixed feelings. There's mixed feelings on the standby. But if you're
There's definitely mixed feelings about the standby list.
But if you are going to put somebody on the standby list, mixed feelings are kind of independent. Put it in the note. We will.
I would keep them on the regular list and do 1 or 2 times a week.
Yeah.
Where you say I'm gonna see the patient
1 or twice.
But if you're not going to see the patient on the weekend, just say, we'll see you again on Monday. But if you need any assistance on the weekends, call the fellow at that phone call. So it's about. That's our main way of communicating, right? We cannot pick up the phone and call it.
And those patients where it was once a week or twice a week, depending on what regimen they were starting multiple antibiotics. And then the weekend we had a little dot quiz. See you again Monday. Revamp it's a long holiday. We say we'll see after the holiday. Call if anything urgent happens.
Yes. Yeah,
letting them know.
to be clear, so that they know what to expect.
Clear on size.
I would offer the caution here, because some of our colleagues who, and I'm talking about not in the division, I'm talking about whether it's in, departmental side, college side, don't always read the notes, or they won't even sign the notes for a while. I had this problem here with SICU where, some of the faculty won't read the notes. So I actually will call them and tell them, this is in the note, but I'm telling you now what I think you guys should do. Again, we're consultants, secondary physicians. We are not primary care physicians. If we wanted to do that, then that's fine. But at an academic institution, ACGME rules state that the primary team has to be putting in 70% or more of the orders and also be doing most of the managing. So we can suggest and hover over the patients all we want. But if the primary team is going to do what they want to do, that's what they're going to do. We see this evidence with the antibiotic stewardship program here at the VA, where we actually track what the fellows, Uriel just got off now, he just got his report, and there were a few cases where the primary teams refused to listen to our recommendations. And again, that's the beauty of America. However, even though we are, we think it's best for the patient, like Guy is saying, with standard of care, with guideline, based, decisions, and also with evidence, science, but still people will do whatever they want to do. So, you can advocate and do the best you can, but at the same time, it's, you can't hover over these people, because all you're going to do, and I think someone mentioned this, there are acute patients that you have to see. And we can't do everything. We're not cephalopods with 8 to 10 arms and 3 hearts and able to do those kinds of things. So that's my tuppence on this issue.
No, I agree with Mel. Sometimes people don't read the notes. I mean, Jessica and I had a patient that was on tough, and they reconciled entecavir, and they consulted us to know if he needed to be on entecavir, and I had done a note a month prior saying no longer
he's not on it, so he's not on it.
So I think the patient and ask him if he's taking it or not, and then you can say, I need just breathe in and you feel your pain. But remember, in the private world, if you guys are going, these if your consultants are your commission, this is what you live off of, strive off of. So breathe in, keep calm, and keep going.
I guess
I have something from the chat. She said she used to have all separate blood lists that she intermittent check on for just cultures and have a quick testing presence.
More be curious.
Thank you for doing that. I'm not doing that. And then she just got told by a hospitalist that all she does is replace potential. I should be ordering the bone marrow biopsy culture.
What?
That's ridiculous.
Excuse me now.
I love culture is very.
It's so bad.
Like biopsies, antibiotics, putting out patients' scripts.
But this demonstrates where medicine is heading, where we see, and this is probably the real point about this discussion is, it's not my problem, it's yours. And that is not, why we are all doing what we're doing and, trying to better, medicine and to teach and to do other things. Again, we don't live in a private practice world. I mean, TGH kind of is in a way, but that's not the credo of why we're in academics. And so it's for other people to really, really, really understand, why we're here, what we're doing. And for a hospitalist to say something like that, to be honest, I mean, that person should get out of medicine because their heart isn't in it. They're just there for, for their own reasons. But that's not the mission that we as a university should and as faculty should be doing. It sounds like this person's possibly private, but from what Divya was kind of insinuating, but at the same time, that's not what we're trying to do. That's just my thought.
Guys, let me get to the home stretch. I'm almost there. All right. No, this is done. So I felt a little slightly attacked when I saw this. It's just an editorial commentary. Another new antibiotic for skin infections and why ID specialists are hypocrites. So initially I was like, this can't be an ID doc who wrote this, but it is a Dr. Lauren Miller from Harbor UCLA Medical Center, who's a ID and MPH doc. And it was a little thought provoking, so I think we'll end on this. So one of the things that he writes in the paper, ID specialists are unique in the medical world. We clamor for sorely needed new drugs, and when these drugs are released, we typically do everything in our power to minimize their use. So he kind of talks about staph infections, Staph aureus infections, and talks about delafloxacin, which is this new quinolone. It covers MRSA, covers Pseudomonas, doesn't have the QT prolonging effects, but still has some of the tendon side effects of the quinolone class. And how the thing that he draws a parallel to is Vanc. I guess this is before my time, of course, but 60 years ago when it came up, they actually called it Mississippi mud because it was so impure and it was like a muddy brown color, so that's what they called it. And at that time, reserved for serious beta-lactam allergies and rare resistant infections. And so he's saying now, it's one of the most commonly prescribed antibiotics, even though that was the thought process at that time. So he kind of draws a little bit of a parallel to delafloxacin and how, it's not really used and we don't want people to use it. But, there's also concerns for easily developing resistance, which has happened with quinolones previously. But he's saying, maybe we should give these antibiotics a chance because maybe it can become a mainstay in the future and that we come off as hypocrites. But that we act this way because we know our role in stewardship, which is the other side of it. So I'll end with that. Food for thought. I don't know if anyone has any.
I did what we were just talking about. So I love that was a very, how should I say, but it was more like a private, but it's still academics. But like we wanted around a cyclone instead of doxycycline. So we did a presentation in the stewardship committee where like doxycycline side effect profile is horrible. I like it. We like around a cyclone more. Immediately they gave it to us. And the other thing I enjoy looking at going over with fellows is, look at your antibiograms for each place. Where I was, MDRs were all over the place. Like a patient who came in for UTI, not transplant, immunocompromised, they had MDR for some odd reason. I don't know what's in Houston water, but and then I'm talking to Dr. Henley, and he's like, yeah, we don't see them here. Like I'm off it at least compared to where I was. So, I mean, it's gonna depend on where we use it, I guess. But like, I gotta say, it was a lot easier to get certain type of antibiotics over there for us to use. And then I worked at other hospitals where it's like much harder. It depends on the stewardship, it depends on I think your antibiogram where you are too. So, but I mean, it's a good, unique perspective to see what, I think we should do a stewardship, of course, but I think we also need to be more open depending on where you are and how.
Right, as far as some of these new drugs too, like you got a cheap option versus the new shiny thing. Even if you want to use it, the hospital's going to be like, no, I don't think so, dog. So I mean, there's a little bit more to the story, I think, than that quote's making out to be.
It's a tongue-in-cheek article.
It is, without a doubt.
Especially with the title.
Yeah, it's highlighting an important part that we do stewardship, but also pointing out, the hubris of the field, and that certainly there's situations where you should be using some of these newer drugs, particularly if they have an advantage over others. It's also important to know your microbiology. I know kind of what you're talking about here with Staph aureus. Vancomycin, how often is Staph aureus going to get rid of resistant vancomycin? I mean, you're talking like true vanc-resistant Staph aureus is a handful of cases. I mean, you've got Visa, but it's not true resistance. So it has a high barrier of resistance versus something like all the other quinolones for Staph aureus. One mutation, done. I mean, delafloxacin hasn't been in practice as much to know if it's going to have more durable. That's part of our job too, is knowing when to use certain drugs, when not to. But I do agree with kind of the highlights of you don't need to be dogmatic about you should never use a newer drug because there are clinical scenarios when they may have a benefit over some of our older agents and just knowing when to push, when to not, and ultimately part of the stewardship aim is not necessarily to restrict antibiotics for the patient, is to make sure that you're doing the most targeted drug with the least amount of side effects, and then also preserving that for the future patients kind of coming forward. So it doesn't mean you shouldn't use more or newer drugs or other drugs like that. It's just kind of being smart about when you choose to do so.
We're done. Thank you, everybody. Appreciate it.